So what is ARNI? Basically, it is sacubitril valsartan. It's an angiotensin receptor neprilysin inhibitor. Valsartan, everyone knows, but neprilysin inhibitor is the combination, and that has become a milestone in the treatment of patients with heart failure with reduced ejection fraction. But heart failure with reduced ejection fraction is just one spectrum of heart failure. There are moderately reduced ejection fraction and preserved ejection fraction. The only molecule at the moment which has been effective in all ranges of heart failure has been SGLT2 inhibitors. But this talk is also to let you know that there are extended indications for ARNI now. It's not only that the Paradigm HF trial clearly showed that it's good for heart failure with reduced ejection fraction. Now there is a Paraglide trial which is showing that for heart failure with moderately reduced ejection fraction, ARNI is also the drug of choice other than SGLT2 inhibitors. Now, the evidence for sacubitril valsartan across the heart failure ejection fraction has been a little, suspect. It's skewing towards the Paradigm HF trial. But after following stabilization in decompensated heart failure and preserved ejection fraction, the trial which has come out is the Paraglide heart failure trial. The transition trial was for any patient who was admitted with acute decompensated heart failure, where we could start ARNI as soon as the patient was off inotropic supports, as well as once the patient was stabilized, but before discharge. That is very important. And the Paragon HF trial was basically closer to the time of a hospitalization event, whether there was a potential benefit. So there were ARNI outpatient, whether it is improved, keep it improved. In hospital, there was a Pioneer, Transition, and a Paraglide HF trial, and the Paragon HF trial, which was after hospitalization. So the incremental factors when you add an ARNI is almost to the tune of around 38%. And this is important of reduction in cardiovascular death and sudden cardiac death. Now, if you ask me, whether we should be aggressive at the time of post discharge of a patient with heart failure with reduced ejection fraction, maybe had a PTCA before, had a CABG before, and should we give these patients ARNI? Yes, because 20% of patients who come to us with reduced ejection fraction after having undergone a CABG or a PTCA, 20% have a chance of sudden cardiac death. And this is what ARNI can protect that patient against. ARNI also is proven to have a reverse remodeling effect. This has been proven by not only the LV ejection fraction, but the volume indices improve. It's not only the LV end diastolic volume index, the end systolic volume index is also the LA volume index and the E prime. So all this have clearly shown that from the baseline to 12 months, this is the actual improvement in the indices when you have such patients. So it's not only just subjective data, these are objective data. There are also cardiac MRIs which have done this study, and we also have PA pressures. That means you float in a Schwann-Ganz, and people have studied the reduction of the pulmonary artery pressures correlated with an ARNI being on board. Now, when you look at the slope of the decline of the EGFR, ARNI definitely reduces the EGFR slope decline, and that is seen in the Paradigm HF, and that is what the benefits are there for heart failure reduced ejection fraction. And maybe the potential mechanism is by improving the ejection fraction, improving the cardiac output, and that is where ARNI plays an important role. Now, the renal outcomes are also out there for you to see in the Paraglide HF trial and the Paragon HF trial in moderately reduced and heart failure with preserved ejection fraction. And this is important in this talk, that there are extended criteria for use of ARNI now. We can talk about ARNI, that it can be used in a moderately reduced ejection fraction category as well as a preserved ejection fraction category. And what we see is that there's a 40% risk reduction in renal composite endpoints. I won't get into these details, but it is uh, improving the cardiorenal protection across the various continuum of cardiac of kidney risk according to the various scores. And then ARNI definitely reduces the cardiovascular death and heart failure hospitalizations in patients post revascularization, whether it is PTCA or whether it is CABG. Introduction of ARNI for this category of patients, whether it's pre-op or post-op, maybe we'll take it up in the panel discussion later, but it reduces the risk of cardiovascular death and heart failure hospitalization in this particular category. Now, what about this Paraglide HF trial? This is a very important trial. It is used for mildly reduced or preserved ejection fraction patients, and this is where the extended use of ARNI comes into play. Now, ARNI can be used in patients with LV ejection fraction more than 40%, and that is what this meta-analysis shows. So, Paraglide HF trial took 466 patients with recent worsening heart failure events, that is defined by heart failure hospitalization, urgent heart failure visit, or an ED visit within 30 days after the index admission. The Paragon HF trial was 622 patients with recent heart failure hospitalization with less than 30 days. That is like it almost considers an in-hospital kind of issue. So when you look at the total pool of 1088 patients, they looked at the primary endpoints of total worsening heart failure events or cardiovascular death, and they found that just using valsartan or using ARNI changes the game, and you'll find that the numbers needed to treat are 27.5 here and 34.5. So obviously there is a huge benefit of using this molecule when you have and this is the forest graph which shows that there is a favoring towards the sacubitril valsartan, that is the ARNI group, for the patients in this category. And the summary was that there is evidence supporting the use of ARNI in patients with heart failure with mildly reduced or preserved ejection fraction, particularly among those patients where an LVEF is below normal, regardless of the care setting.